ineffective erythropoiesis, iron deficiency and pernicious anemia are the common types. So we report a case of 18-year-old female who came to the casualty with chief complaint of blurring of vision, yellowish discoloration of both eyes for last 10 days and generalized weakness for last 7 days. Defective vision was sudden and painless in nature, associated with yellowish discoloration. Patient was treated for anemia 2 weeks back with 5 blood transfusions and was discharged with normal hemoglobin levels. Then she developed fever, chills and rigors and generalized weakness for last 7 days. Personal history showed high-colored urine. Treatment history showed 5 blood transfusions. Pallor and icterus was present. Visual acuity in right eye was 6.9 improving to 6.6 and left eye 6.12 with no improvement on pinhole. Conjunctival pallor and yellowish discoloration of sclera was noted. The fundus examination showed media and optic discs were normal, blood vessels dilated and tortuous, macula in right eye FR was altered. In left eye it was not seen due to a pre-retinal hemorrhage over the macula. Background retina showed multiple flame-shaped hemorrhages, Roth spots, cotton wool spots and a few pre-retinal hemorrhages. Investigations showed raised MCH, MCV, MCHC and ESR levels and highly raised LFTs, especially the LDH level. Other parameters like hemoglobin, RBC and PCV, vitamin B12 were reduced and reduced RBC density with anisocytosis was seen. Anti-nuclear antibody double-stranded DNA and indirect direct Coombs test were positive. Ultrasonography showed mild hepatosplenomegaly. Mainstay of treatment was oral prednisolone in tapering doses and hydroxychloroquine with eye drops nepafinac 0.1%. This is the fundus photographs after 5 months of treatment. It shows there is complete resolution of hemorrhages and cotton wool spots and vision was also improved to 6.6 in both eyes. Provisional diagnosis of anemic retinopathy secondary to autoimmune hemolytic anemia due to systemic lupus erythematosus. Differential diagnosis include leukemia, infective endocarditis, dengue hemorrhagic fever, coagulopathies, CRVO or BRVO, diabetic retinopathy. Discussion includes anemia induces retinal hypoxia leading to nerve fiber layer infarction which presents as cotton wool spots. Retinal hypoxia prompts vascular dilatation, increased transmural pressure due to hypoproteinemia, vessel wall microtraumas which lead to retinal edema and hemorrhages. Other factors like venous stasis, elevated blood viscosity, hypotension post-hemorrhage and angiospasm lead to optic neuropathy. So the take-home message here is as the severity of anemia increases, the risk of retinopathy also increases. In most cases, only treatment of underlying etiology is needed and retinopathy generally resolves on its own. Most of the patients are unaware about their anemic condition, which may be first detected by ophthalmologist. However, detailed pathological examination is required to detect the type of anemia. These are my references. Thank you.
It's a good case. What is the level of these, location of these hemorrhages usually?
The superficial flame-shaped hemorrhages are mostly at the nerve fiber layer. The dot blot hemorrhages or the Roth spots are seen at the deeper layers.
And you also showed a lot of large hemorrhages.
Yes, pre-retinal hemorrhage, yeah. Those can be either subhyaloid or sub-ILM. But here we have seen the subhyaloid type of pre-retinal hemorrhage.
Very good.
Is it not the iatrogenic due to some drug induced?
No, ma'am, it was idiopathic. Because she had no other clinical features also, no butterfly rash or no arthritis or any kind of.
Has she taken some treatment for this fever and all these things you told?
For fever, she took normal tablets, and for anemia, she was treated with blood transfusion outside. But even after taking blood transfusion, her blood count levels kept on decreasing.
Nothing like quinine or anything?
No, ma'am.
In this case, anemia was secondary to the SLE. Yeah, so when you see such a thing, you have to be very alert. It could be a blood malignancy. Our first thought should go to blood dyscrasias.
Yes,
and investigate for that. Lymphomas, leukemias, associated thrombocytopenia may cause more severe hemorrhages.
Yes.
Infections. So yeah, we have to, actually we should hand them over to the physician.
Yes. In our case, when the blood reports came back, anti-nuclear antibodies for double-stranded DNA was specifically positive and the titers were also highly raised. It was +3. So it indicated systemic lupus erythematosus. So we didn't proceed for any malignancy and she was responding well to the treatment also.
No, but just because the ANA is positive, that would be positive for half of us here. That doesn't mean we have SLE. So we still have to investigate for everything. If one thing is positive, we don't not investigate for other things.
Okay.
Because that may be a coincidental finding.
Yes.
So any such patient, but that's not really our area. Once we say that we are suspecting this, possibly a physician can
Physicians will
investigate.
do
Yes.
But we should also, I mean, at least.
Actually, the peripheral blood smear for comments
Yes.
should be done.
Yes. Well, physicians have followed the case, and with their collaboration, we have treated the patient.
Okay, next case.
Yeah.
Thank you.
Thank you. Very
Thank
good
you,
case.
Is Dr. Murlidhar Pari here? Dr. Saurav Das? Dr. Divya Kanduri? Yeah. So Dr. Divya will be presenting a case on toxoplasma neuroretinitis case series. Is intravitreal a good alternative to classic oral therapy?
Good morning everyone. So I'll be presenting toxoplasma neuroretinitis case series, and we'll see in the further. So neuroretinitis is commonly due to infectious causes. Due to toxoplasmosis, it is very uncommon. Typically ocular toxoplasmosis will present with a headlight and fog appearance with white focal retinitis over the overlying vitreous inflammation and adjacent pigmented retinochoroidal scar, vitreous inflammation, secondary non-granulomatous iridocyclitis can be there, KPs can be seen, ocular hypertension and retinal vasculitis can also be seen. But in atypical cases, we see retinochoroiditis, papillitis, neuroretinitis, retrobulbar neuritis, scleritis, retinal detachment or punctate outer retinitis can also be seen. So, moving on to our first case, the patient was a 48-year-old male who presented to the IOPD with complaints of painless progressive diminution of vision in the right eye since 2 months. He had a history of pet dog, and he was a hypertensive. On antihypertensives, he had controlled hypertension. On examination, his BCVA was right eye was finger counting close to face, and left eye it was 6/6 partial, and in his pressures were intraocular pressures were normal, and slit line examination anterior chamber findings were normal, but we could see vitritis +2. So his fundus photograph here shows that there was a vitritis +2 with massive disc edema with blood margins, and superficial flame shaped hemorrhages and macular edema were seen. Active choroiditis choroid retinite patch was also seen inferior temporal to the fovea, while the left eye was normal. On OCT at presentation, his OCT showed a dome-shaped elevation below the RP, showing the choroidal thickening and disorganization of the outer retinal layer, which showed that it is a chorioretinitic patch. There was a hyporeflective space, that is subretinal fluid was there, and subfoveal deposition of hyperreflective spots were also seen. So moving on to our second case, we had a 50-year-old male who presented to the OPD with same complaint. He had a history of pet cat. There was no systemic diseases, and on examination his right eye vision was 2/60 and anterior segment was normal with vitritis +2. His fundus photograph showed that there was disc edema with hyperpigmented active lesions in the parafoveal region with hemorrhages around it. And on OCT, it also showed that there was a disc chorioretinitis patch. Subretinal fluid was seen in the right eye, and ERM was also, epiretinal membrane was also seen. His central macular thickness was 368, and his left eye had normal findings. And another case, which was a 29-year-old female who presented with the same complaint and the history of pet dog with no systemic examination. On examination, his left eye, her left eye was 6/60 vision, and her anterior chamber findings were +2 reactions, that is uveitis was present, stellate KPs were seen, vitritis was there. So her findings is this patch with 2 disc diameter in parafoveal region. Her OCTs showed the same picture with few cystic lesions. Then all 3 patients had history of painless diminution of vision, PET had vitritis, and typical choroiditis scarred lesion were absent in these cases. So we investigated them, and the serologically and anti-toxoplasma IgM and IgG were positive, and we diagnosed them as left eye toxoplasma neuroretinitis, and we treated them with intravitreal clindamycin and dexamycin on presentation, and repeated the injections at 1 and 4 weeks. And on follow-up at 1 week, we can see that disc edema is resolving, the patch has been resolved. On 2 week, the case 1 showed that visual improvement to 6/12 and decrease in disc edema, as well as the hypopigmented patch and hemorrhages. At 6 weeks, there was complete resolution, and Second case also showed the same thing. Then third case, we can see that there was resolving of the chorioretinal patch, and at 4 months now the follow-up, there was a complete resolution of the active lesion with scar formation. So we can see that without trimethoprim and pyrimethamine, we have treated the patient with IV intravitreal clindamycin and dexamethasone only, and thus we have got the good results. So we came to the conclusion that since there are less studies, further perspective clinical studies should be needed to validate the efficacy of intravitreal clindamycin as first line treatment for the cases of toxoplasmosis.
So the rationale in giving a more invasive form of treatment?
Ma'am, actually the thing is that the patients were far away from hilly regions of Uttarakhand, so they had a less follow-up visits, and they were keen for immediate treatment and less follow-up. So we just asked them to come for in intravitreal injections and then follow up at 4 weeks and 6 months. That's it.
See, when you're giving an invasive treatment like that, first of all, are we sure about the diagnosis? That's very important.
Right,
so you could have a differential in these cases. It
Yes,
could be
ma'am.
candida.
Yes, ma'am. Tuberculosis,
It could be any
infectious and
tuberculosis. Yes,
autoimmune, we both
syphilis.
can. Right,
So
ma'am.
it's okay, you're
Yes,
giving
ma'am.
clindamycin, but that is invasive, as she said, and there is a risk of endophthalmitis also with each injection. So we have to be reasonably clear about the diagnosis. In the first case, there was very severe manifestation.
Yes, ma'am.
So when you give steroid along with that, when you don't have a clarity on the diagnosis, could there be a worsening of the disease if the diagnosis is different and now you've added steroid as well?
Right, ma'am. It can be if it is infectious disease, so it
Can
can.
we not just give clindamycin and not give dexamethasone? You can give oral steroid if you want,
Yes,
so
ma'am.
that you can at least stop when
Add
you
up
want.
the.
But you cannot withdraw dexamethasone that you have injected.
Right,
So
ma'am.
I would say that just clindamycin would be good enough. And as Madam said, probably oral therapy is good. If in cases that are intolerant
Yeah,
for any reason, possibly we can
and
add it.
non-compliant.
Yeah, because every intravitreal carries a risk of endophthalmitis also.
Right, ma'am.
It's not, and clindamycin we have to reconstitute. It's not available like Lucentis or Eylea. So when we reconstitute, the risk of end-off goes high.
Right, ma'am.
But overall, yeah, I have used clindamycin quite a lot now. And yes, the response is very good, and the side effects of the systemic therapy are all avoided.
Less. Yes, ma'am. Thank you, ma'am.
So we should be cautious when giving periocular steroids, especially in patients with toxoplasmosis, without giving anti-infective drug. It can flare up
We
the
covered it
infection.
with the antibiotic.
Any infection actually.
Any infection,
And I think
more so.
with intravitreal, if you are giving clindamycin, the systemic treatment is also important because toxoplasmosis causes so many things.
Right, ma'am.
Though currently, I mean, if patient is intolerant, you can just give intravitreal also.
Yes, ma'am. Thank you.
Yeah.
The next speaker, Dr. Nimisha Kaushal. Dr. Sandeep Kumar. So Dr. Sandeep Kumar will be presenting a case on reperfusion of choriocapillaries in a case of CRVO combined with cilio-retinal artery occlusion.
A very good morning to you all. I'll be discussing a case of reperfusion of choriocapillaries in case of CRV combined with cilio-retinal artery occlusion. An 80-year-old diabetic and hypertensive male presented to us with on-off history of transient blurring of vision in right eye for 4 weeks. On examination, there was diffuse increased tortuosity and venous dilation. There were retinal hemorrhages in all quadrants. The left eye was within normal limits. Scans were normal on that presentation, so we advised a full cardiac checkup, carotid Doppler, close follow-up, but the patient didn't get it and presented to us within next 7 days with a drop in vision to 6/60. I apologize for the absence of color photo because there was some technical failure that day. So this is a 15/9 octa image, superficial slab, which shows a lot of CNP areas, tortuosity, and probable CME here. The region supplied by cilio-retinal artery appears a bit fuzzy, but it still has blood supply. So but when you take a choriocapillary slab, we could see the corresponding zone shows a wedge-shaped defect, void in flow in the choriocapillary slab. A B-scan, SD51 scan confirmed the CME, and inner retinal hyperreflectivity confirmed the cilio-retinal artery occlusion. So we started with anti-VEGF, but the patient presented on the 7th day with vision drop to 3 meter, and there was a full-fledged ciliary-retinal artery occlusion that day. Left eye was stable at 6.9. We did a angiogram. There was a delayed arm retina span of around 32 seconds. There were blocked fluorescence. There was a lot of CNPs, and there was no flow in the ciliary-retinal artery area, even in the late phases. Post 2 weeks, we are following it very closely. Post 2 weeks of the injection, the CME has resolved, but the inner retinal hyperreflectivity suggesting ischemia still persisted. This is after the color photo on the 2 weeks. After 2 weeks of the injection, the ciliary-retinal artery area, this hyperreflectivity had become more consolidated. The hemorrhages have resolved, CME had resolved. So this is the patient presented after 6 weeks of injection. We could see how the CNP areas have become more defined here. Probable NVEs in the periphery, formation of collaterals at the posterior pole, and the area supplied by ciliary-retinal artery. We can see there is retinal whitening corresponding to the retinal whitening area. It's a non-perfused area. Corresponding area, and on the choriocapillaris slab, you can see that there was the flow void was becoming less prominent now. And as the pressure was rising up to 31 mm, we suspected NVG and we did tight PRP and asked him to follow up. The patient presented with a history suggestive of transient ischemic attack. So we immediately referred this time for MRA and carotid Doppler, which showed severe stenosis seen at the right carotid bifurcation with around 75 to 80% luminal narrowing. And there was a carotid bulb mixed density plaque at the carotid bulb on the carotid Doppler. So we referred him immediately to the neurophysician. So the points from our case is emerosis fugax, which we take the patients and even the doctors, they take it very lightly at some times, because here is suggested that this is seen at least in one third of the patients of the combined vascular occlusion. They have it sometime before the onset of the constant blood vision. Second thing, SSOCTA we feel can help in localizing the level of the block. So if you see, this is at the time of the first presentation, this is a CRBO presentation, and what we can see, the area supplied by the ciliary-retinal artery is still perfused, but at the same visit, the choriocapillaris slab shows there is a wedge-shaped defect which denotes a void in the flow. So what we can, we suggest that the block has been in the ophthalmic artery right before it was before the central retinal artery and this it bifurcates from the ophthalmic artery, so that both of them get involved spontaneously. So, and other thing is the choriocapillaris has not been has been suggested that it is involved in combined vascular occlusion, but in our case, not only it was involved, but it also got reperfused over the period of time. We can debate over this, that it can be because of the retinal whitening area, but if we see the corresponding flow void areas, it was same, and it kept getting better over the time. And it was present even before the white area was present in the ciliary-retinal region. The white area, when it came, it is still present at the end of point when the reperfusion was there. So to conclude, the case highlights the use of SSOCTA as an important imaging modality for diagnosis and follow-up of a combined vascular occlusion. The excellent documentation of the capillary dropout areas on the wider montage view obviates the need for FFA during follow-ups. SSOCTA can help in deciding the level of block. Thank you for kind attention.
So the patient had emerosis fugax.
Yes, ma'am. For
and
4
then
weeks.
He landed up in ciliary-retinal artery occlusion.
Ma'am, he was having it for 4 weeks, okay. And then he presented to us for that only. We saw everything was fine. We just asked for a cardiac checkup. Come to us, but he was like, "I'm fine. It is happening once in a while, so let it be." And within 7 days of that, he presented with a drop in vision to 660. That time he had a CRBO with full CME, and the ciliary-retinal artery region was fluffy. It was not that white thing. And when we did, it was shown on the choriocapillaris, there was a wedge-shaped defect that was corresponding to that white region that appeared later. So it was occurring, it was like ciliary-retinal artery in progress.
Yeah.
That was like.
It was evolving actually.
It was evolving, yes, ma'am.
But are there reports of the ciliary-retinal artery getting reperfused when it is associated with CRBO?
Yes, ma'am. They have, now there's, with the advent of this OCTA, there have been a lot of reports of this reperfusion. So
and vision, does the vision significantly improve?
No, vision, it depends. See, there was, we couldn't follow up actually because of this MRA thing. He had a very huge block. I think he went for a stent surgery for that. So we didn't follow up after that. He didn't came back. His left eye was doing fairly well, so he didn't turn up, I think. And it was around, it's 2 years back.
If the cilioretinal artery reperfuses soon enough, we would expect vision improvement also, just the way we have in CRAO also.
Yeah, it took around 12 weeks to get to the last point, if I may show. This thing, sorry.
So the reperfusion took 3
this
months.
thing, this last is of like around 3 months.
And the carotid occlusive disease as a etiology for CRVO? Do you think so? Carotid occlusive disease, you said, is the etiology for in this patient.
There was occlusion at both, at the carotid branch, in carotid bulb, and the right carotid artery branching at the point at the bulb.
What Dr. Gayatri is trying to say, in CRVO, there is less or no role for carotid involvement.
Yeah.
So the fact that you investigated itself is surprising, but that you got a positive finding and you could treat is a good thing. However, in CRVO, we generally do not do carotids. We see carotids for CRAO or artery occlusion, central retinal artery, or in this case you had a cilioretinal artery, or we do it for anterior ischemic optic neuropathies.
Yes, ma'am.
Or ophthalmic artery occlusions.
Yes, ma'am.
But not for venous occlusions is what I think you're trying
Yes,
to
ma'am.
say.
So there's one thing, the amount of ischemia progression, that was that led us to think like there were carotid development, because the way it was progressing, the ischemia was progressing very fast, and the pressure, there was no NBI at that time when we did the laser and everything. The pressure got controlled. It went to around 20 after like 4 or 6 weeks of the laser, but we ordered that thing so that we don't miss it.
If you have those reasons, there is no harm in doing
and it was because we could follow it up very regularly, 7 days on octa, so we could document. We couldn't do this FFA. Thankfully, we didn't do in a patient of this block. So, and he was an 80-year-old patient. We could not repeat FFA so frequently. So SSA OCTA helped us in this thing.
Whether he was dyslipidemic?
Sorry, ma'am? He was on blood thinners, ma'am. He was hypertensive. He was diabetic, but he was 80-year-old. He was controlled, like 7.5 was his HbA1c. He was said, I can't go beyond this. 7.5 for 80-year-old is fairly, actually.
It must be a generalized process.
Yes, ma'am, it is like, yes, must be. So we couldn't follow up after the neurophysician.
Go to the next case now.
Sorry?
Thank you.
Thank you, ma'am.
Is Dr. Sneha Batra here? Yeah, so she'll be presenting a case on central retinal vein occlusion in a 15-year-old boy as a presenting symptom of protein S deficiency.
As a side comment to that one, nowadays the availability of OCT angio definitely has made it very easy to diagnose an associated cilioretinal artery occlusion with CRVO. Earlier it was more dependent on visual acuity or some doubts, but now with the OCT angio you can confirm it easily. And the advantage is you can give a poorer prognosis. Even if the CME goes away with your injections, the visual prognosis is worse. Yes, Tom.
Good morning, everyone. I will be presenting a case on central retinal vein occlusion. We had a case of an 80-year-old just before this, and now in a 15-year-old boy as presenting symptom of protein S deficiency. So CRVO in the young is now becoming more and more common, and it constitutes around 10 to 15% of all CRVO cases. In these cases, hereditary thrombophilias constitute a major risk factor, and we do screening tests for them. But protein S deficiency is a very rare condition. However, it is an important condition, as we saw in this case. So this 15-year-old boy presented to us with a history of sudden painless dimness of vision in his left eye for the last 1 week. He was diagnosed elsewhere as optic neuritis, and he had already been started on oral prednisolone tablet. He was taking around 60 milligrams per day at that time. So the right eye, the vision was absolutely fine. Left eye had 6/18 N10. IOP was normal, anterior segment was normal. Coming to the fundus examination, again the right eye was fine. The left eye showed disc edema, numerous flame-shaped hemorrhages in all the 4 quadrants with vascular tortuosity. So we concluded that this was a case of central retinal venous occlusion. We did an FFA also because he had been diagnosed with a different entity elsewhere, and we saw a very typical picture of CRVO with disc leakage, with vascular tortuosity, some amount of block fluorescence. Not a lot of CNP areas were seen, And on OCT, we could see that there was macular edema with subretinal fluid. The maximum thickness of the maximum retinal thickness was 567 microns at this time. The blood pressure was normal, cardiovascular examination was normal, all other systemic examination was normal. There was no significant family history or past history in this patient pertaining to coagulation disorders. So we made a provisional diagnosis of CRVO of the non-ischemic type. We had a differential of papillophlebitis, but because of the younger age, male gender, decreased vision and presence of significant macular edema, we thought CRVO was the more likely diagnosis. So we advised an injection of intravitreal ranibizumab. We asked to taper off these steroids, and we gave some blood tests to rule out what coagulation abnormalities could be present. Now, interestingly, the patient's mother said that I do not want to give an injection to my son, and they did not come back on the day of the injection. They came back after 1 week, and she said, my child is feeling much better. The vision had improved 1 line to 6/12 in 8. And they came back with the blood tests also, which showed protein S deficiency. We referred to a hematologist who started him on warfarin. All the other blood tests were normal. The homocysteine level, protein C, antithrombin, everything was fine. So we did not give the injection because the patient was feeling better. We followed him up, and after 10 days, the vision had improved. So this is the first picture when they had come back after 1 week. 299 microns of CST, some amount of subretinal fluid present, and after 2 weeks, the subretinal fluid, macular edema, all had gone, and the vision had come back to 6/6 N6. So CRVO in the young is less than 50 years old. Of course, hypertension, diabetes, and hyperlipidemia are important. Additionally, these thrombophilic risk factors need to be investigated, hyperhomocystinemia being the most common one, but some of these uncommon diseases also have to be probed. The family history is very, very important. What is protein S? It works as a cofactor of protein C to prevent the activation of factor X and thrombin in normal physiological conditions, hence preventing thrombosis. So most of these children, if it is a homozygous deficiency, it presents right in the infancy, and if it's heterozygous, it presents later, and lifelong anticoagulation treatment may be required in these cases. So it is a very rare case, and in India we could find only 1 prior case of CRVO with protein S deficiency. We saw another study of 50 young patients with CRVO. None of them had protein S deficiency. So it is uncommon. The literature suggests that intravitreal ranibizumab is the first line of treatment. However, CRVO in the young may have a predominant inflammatory component. Some people have tried out dexamethasone implant also, but the treatment in this case was not in our hands. The steroid had already been started due to a misdiagnosis, and we saw that there was a rapid and uneventful recovery. So can it be a treatment? We are not very sure. We would probably still suggest ranibizumab as the first line of treatment, but it is something that I wanted the house to discuss as well. These are my references. Thank you.
Good case. Very interesting case.
Thank you.
You're right that CRVO in the young, many times we see significant recovery without treatment. And earlier, about 15 years back, we used to give oral steroids as the treatment for young CRVOs, and the diagnosis was papillophlebitis,
Right.
or the Lyell-Weber syndrome, where it is believed to be an idiopathic inflammatory disorder. So with that understanding, the conventional treatment was oral steroids only.
Okay.
Then we stopped giving oral steroids, at least because for various reasons, but we still do not need to immediately treat them. Many of them recover spontaneously. Oral steroids can be given, and then if you end up giving an intravitreal, most of the time they don't need more than 1 injection. They hardly have recurrences. But now I'm talking of idiopathic ones. I'm not talking of somebody who has a known etiology where we might expect recurrences also. So I'm not speaking about your case, but this is in general for most young patients.
Okay.
And of course, in a young patient, very thorough workup. You picked up a very rare disease which we don't even investigate for mostly.
Yes.
But we generally should investigate for all kinds of inflammatory diseases like sarcoid, SLE, vaginous, even leukemia, lymphoma, and other homocystinemia, in addition to diabetes, hypertension, dyslipidemia.
Yes.
So it has to be a very thorough workup. Before we say it is idiopathic, Most of the cases in the young are idiopathic inflammatory. Most of the cases, you will not find the etiology. When in COVID times, we were getting cases post-COVID infection or post-vaccine with CRVO. And again, most of them were resolving with oral steroid and anticoagulants, warfarin or whatever. Only a very few of them required an injection.
Okay.
This
Yes,
protein S deficiency, this is due to the mutation.
Yes, ma'am.
So this is going to be recurrent. So
Yes.
they say we will have to stop it and do the counseling
Yes, ma'am.
and do the genetic analysis in
Yes.
these patients.
Yes. So we had, yes, ma'am.
Anti-coagulant, I think the diluted heparin is better than the
Okay.
And since they are now on anticoagulation, we may not expect to see recurrent
Yes.
events.
Recurrences again. So we had referred to a hematologist. He had suggested the warfarin to be continued lifelong.
Any questions from the audience? We have some time, so anything? Okay, next please.
Thank you.
I invite Dr. Sophie Rinth, if she's there around. Dr. Sophie?
So we finished 15 minutes ahead of time. Can we have some discussion, please? Any of the cases that were discussed or any important points? Yeah, she can take the cordless.
only 4 cases were
In the previous case, I would like to know, without giving an AIOCMT3, though the mother didn't wanted to get it done, so the vision has improved 6:12. It's a system 6:6. So what could be that? It's an ongoing systemic problem, and how could the pathogenesis has slightly reversed and the vision? What could be the explanation for that?
Your mic is hardly audible. Keep it.
So as Madam also said now, retrospectively we feel that it was an inflammatory component which was maximum present, and the oral steroids which had already been started, we were tapering them off. We did not stop it. He was already on 60 milligram, which was more than his body weight also. So we had tapered it off weekly. So he was actually on some kind of treatment, and because it had an inflammatory component, and as Madam said, in some cases there is a recovery which is very, very unusual and
Most
very
cases
fast.
they recover.
Thank you.
CRVO of the young is generally a very, very good prognosis situation. We can tell the patients to relax, we should not even give injection in the first 2-3 weeks because it might resolve. That's possible. Because he may not be having any predisposing factors like the No, definitely. Why can't you comment? You can comment. You can even publish. We have published cases of post-vaccine CRVO, which was the first documented in the world. So why can't we comment? We are free to comment. Okay. Anything else? Any other questions? Any other comments? Experiences?
As Dr. Malika told, before the advent of the anti-VGF, we were not giving anything and they were resolving itself. If macula is not involved, vision will be very good. So we should not worry, and patient should not be stressed. Otherwise, it will increase the blood pressure and all these things. So even in elderly patient, wait and watch was the thing before.
Anything else?
So glaucoma is one important risk factor in elderly. Especially, you don't need to do a detailed workup in a patient who is found to have high intraocular pressure. The previous patient of CR Vivo, there was this intraocular pressure of 30 millimeters is what I have seen. Was at the time of presentation, I couldn't register what his intraocular pressure was. But if his diagnosis is glaucoma, then and age itself is a risk factor. So, but young patients like these patients whom you have presented, they need thorough workup. Then only comes the idiopathic component, like in your diagnosis. So after thorough evaluation only that one can label young patient with central retinal vein occlusion as idiopathic inflammatory disease.
Glaucoma is a very important comorbidity with RVO. So if you have a patient of RVO, take time to see his intraocular pressure, look at the disc again, and the other disc, other eye also, because very commonly they will be having glaucoma, which is the reason for this CRVO also, because the external compression. So we often can miss the glaucoma, and that needs concomitant treatment. So that's a very important point. And the person who presented CRVO, I'm forgetting the name, they also did laser. I think he has left the room.
3 months.
Yeah, he has left.
Yes.
Okay, so they will leave that part.
New vascularization of retina should all be seen.
So shall we close? If there's nobody else wants to discuss anything. Thank you very much.
Thank you.